Okay, what's up guys? Welcome back. This is going to be the third and final video for the pulmonary practice questions. So we'll pick up where we left off. We just finished with Lambert-Eaton myasthenic syndrome. So we'll next go to this vignette here. A patient with a history of smoking comes in with drooping eyelids. He has dry eyes and constricted pupils. So what's that? You also know weakness and atrophy of the fourth and fifth digits along the ulnar aspect of the arm in an ulnar distribution. The patient notes some mild same-sided shoulder pain as well. What is this diagnosis? So again, long history of smoking, and he's having these symptoms. He's having these triad of symptoms first, along with a long history of smoking, and then these ulnar distributive symptoms in that same side shoulder. What is this? What is the triad called? And where is this pathology located specifically? So this is going to be a Pance tumor. The three symptoms in the vignette were Horner's syndrome, that ptosis, the eyelid drooping, miosis, the pupillary constriction, and anhidrosis, dry eyes. So that's Horner syndrome again, ptosis, miosis, and anhidrosis. This is due to compression of the cervical sympathetic chain as it goes up, and it's located in the superior sulcus or the apex of that lung, and that's why they're having that shoulder pain, especially as it disrupts the ulnar distribution, as it's off the posterior portion of the brachial plexus. The ulnar nerve distributes from there. So if we're having a tumor, it can invade into those areas up into the shoulder. And this is more common in squamous cells. So again, the CCCP, cavitary hypercalcemia, Pance tumor, and centrally located. Next is a patient that is a long-term smoker is found to have, on chest x-ray, unilateral pleural thickening, and states some pain when deep breathing in and out. What is this diagnosis? What is the biggest risk factor for this condition? So that's going to be mesothelioma, a tumor of the pleura itself, and asbestos is the biggest risk factor. And remember, it's synergistic with smoking for the damage done. So the synergism between them lead to more damage than either one alone. Again, that's mesothelioma for those pleural plaques or thickening of the unilateral pleura, tumor of the pleura. Next one is a 2-year-old that has sudden onset of wheezing, choking, and dyspnea. So 2-year-old with sudden onset of wheezing, choking, and dyspnea. You notice asymmetric breath sounds on auscultation. What is at the top of your mind? So again, 2 years old, asymmetric breath sounds on auscultation. What is the definitive or diagnostic management? What location specifically would you expect to find this pathology? So a specific location. And what is the most common thing seen on chest x-ray in this condition? So a few things here again, definitive diagnosis and management, specific location, what is the most common thing you'd see on chest x-ray? So this is going to be a foreign body aspiration. Again, they're 2-year-old, they're having unilateral problems. Unilateral auscultation you're hearing in the lung. Most common in 2-year-olds, and the most common is peanuts. A rigid bronchoscopy is diagnostic and therapeutic because you can actually go in to that right bronchus, the most common area, and take out the peanut or whatever it's stuck in there. And it's more common in the right bronchus due to its vertical structure. So the right bronchus is much more vertical as opposed to the left, and it's much wider as well. Air trapping is what you'd see on chest x-ray because it's a blockage proximally, so there's going to be air trapped distal to that blockage. Next one is a patient that comes in with chest pain. They state they had a viral infection that was had last week. They state it's also worse with inspiration, this chest pain. On physical exam, you find reproducible point tenderness of the chest wall with a notable area of edema around one location, just one location, where the sternum attaches to the rib. So again, important things, previous viral infection, chest pain, worse with inspiration, reproducible point tenderness, and notable edema around only one location. What is the diagnosis, and what else is in the differential, and how do we differentiate it from this condition? So this would be Pance syndrome, I believe how you pronounce it. Could be wrong. So Pance syndrome is due to this. It's post-viral. They'll have that edema, and it'll be more so in one location as opposed to many. Costochondritis, on the other hand, is 2 or more locations on that chest wall, the costochondral junction, and no edema. So again, if it's costochondritis, if it's 2 or more locations and no edema, whereas it's Pance syndrome if it's edema and only one location. And again, costochondritis is much more common. Next one, a patient has a pleural fluid protein to serum ratio of 0.4, and a pleural LDH ratio to the serum of 0.5. What is the diagnosis? So this is the Lights criteria. And what is the diagnosis? What is the most common cause of this specific one here? And what is the pathophysiology in this? So this is going to be a transitive effusion. So it's a transitive effusion. We just use Lights criteria. And Lights criteria says over 0.5 protein, over 0.6 LDH, or over 2/3 the upper normal limit for pleural fluid LDH is considered. Any one of these would be considering it an exudative effusion. So this guy's effusion was lower than all those three. So that would be a transitive effusion. Transitive effusion, the most common cause is heart failure. And then second is cirrhosis, and then nephrotic. So decreased oncotic or an increased hydrostatic brings fluid into the thin lungs. In nephrotic syndrome, we're losing protein, so therefore we're decreasing the oncotic pressure, the ability to keep fluid inside the body. So we need that albumin to keep the fluid in there. And if, again, in nephrotic, we're losing those proteins. Heart failure, of course, increases the hydrostatic pressure because we're just having a fluid overload itself. So that fluid's going to leak into different compartments because it's not moving as well. And cirrhosis, of course, because the liver is not able to perform its synthetic function and produce albumin. Again, just like in nephrotic when we're losing albumin, here we're not even making it. So then we lose that oncotic pressure, the ability to keep fluid in the intravascular space. And of course, in cirrhosis, we have things like ascites and hepatosplenomegaly, etc. So those are your causes of transitive. Next one, will pleural effusions have increased or decreased fremitus? So important one to know, they might tell you, will pleural effusions have increased or decreased fremitus? Name some of the causes of exudative pleural effusions. So what would cause an exudative pleural effusion? And next one, what is the best position for a chest x-ray in an effusion? So if we really want to see this effusion and assess it, what is the best position to put them in for a chest x-ray? And what might we see on a PA film, the classic sign? So there's a classic sign that we're going to see if we do a PA film. So with the pleural effusion, it's going to be decreased fremitus. So remember that fluid transmits the sound, but there's not fluid in the lung, it's in the pleura. So in pneumonia, the fluid is actually inside the lung. That's why we have the increased fremitus, because the sound transmits through that fluid much better. But here we're not going to see that because the fluid is in the pleura itself, which is around the lung. So we're going to have decreased fremitus in a pleural effusion. Some of the causes of the exudative pleural effusion, that's going to be malignancy, infection, inflammation, pneumonia, as well as a pulmonary embolism as well can cause it. Lateral decubitus is the best position to detect less fluid on the PA film, posterior anterior film, because if they're in the lateral decubitus, we're going to have an easier time seeing if there's any loculations or any buildup of fluid in a specific clustered area, as well as we're going to be able to see the thin line, as opposed to if they're in PA or AP, we're going to need to see at least 175 milliliters to actually see blunting of the costophrenic angles. And that blunting of the costophrenic angles, that the classic sign we were talking about, is the meniscus sign. So the meniscus sign, if those are blunted. And we need at least 175, again, milliliters to actually blunt that on the PA. And again, that's why the lateral decubitus is the way to go for identifying a pleural effusion on the chest x-ray. And lateral, like we said, also helps because if it's loculated or if it's an empyema, it won't move from the PA to the lateral when you move the patient. So again, if it's loculated in that specific area, if you put them on the lateral decubitus, that thing is not going to move anywhere. Whereas in a regular pleural effusion, if it's just transitive, it's gonna sink to the area with the most gravity. So it's a good way to kind of help, just based on the x-ray, see what the underlying pathology might be. Next one is a 22-year-old basketball player, so they're probably tall, suddenly has shortness of breath and unilateral pleural pain, unilateral pleuritic pain. He admits to occasional smoking but no drug use. What would you consider in this patient? So again, 22 years old, young male, thin, shortness of breath, unilateral pleuritic pain. He admits to occasional smoking but no drug use. Chest x-ray would show what classic sign? And what is the treatment if over 3 centimeters from the chest wall or over 15% of the hemithorax is affected in this condition? So what would that be again? Over 3 centimeters, over 15% of the hemithorax, so one side of the thorax. This is going to be a primary spontaneous pneumothorax, a PSP. This is due to a rupture of an apical bleb. It's common in thin, tall, young males. No underlying disease necessary, but smoking is a risk factor. This guy was an occasional smoker. But again, it's more so the history with these type of patients that you're going to be seeing that primary spontaneous pneumothorax. The classic sign on chest x-ray is those companion lines, and the description of that is visceral pleural lines running parallel with the ribs. In this case, you want to do needle aspiration because it is over 3 centimeters from the chest wall, or over 15% of the hemithorax. So just a larger area, you're going to want to do needle decompression or needle aspiration of the air. But if it's smaller or less than 15% or 3 centimeters from the chest wall, you could just do oxygen, observe them, repeat the chest x-ray in 6 hours and see if they're improving. Or if not, then you may need to do that aspiration at that point. But if not, you can just observe them for some time, and they don't need any intervention besides supportive and oxygen. What is the most common cause of a secondary spontaneous pneumothorax? What is the treatment for a secondary spontaneous pneumothorax? So most common cause of a secondary spontaneous pneumothorax, we already said it a little bit earlier. That's going to be COPD, of course. So remember in emphysema, they're commonly having those blebs, those apical blebs. We should remember. So that's the most common cause of a secondary spontaneous pneumothorax. And for secondary spontaneous, we always admit them because they have this underlying condition. Of course, it's a secondary condition. It's secondary to something. So they have an underlying condition. We should admit them for this. And we should give them a chest tube or catheter thoracostomy, even if they are stable, to drain that pneumothorax because they already have a compromised lung function, obviously, with COPD. So we need to do more drastic measures for them. Next one, explain what occurs in a tension pneumothorax. So what actually is going on in a tension pneumothorax? It's important to know. And what is the classic triad seen in a tension pneumothorax? Tension pneumothorax. So tension pneumothorax is positive air pressure that pushes the trachea, heart, and great vessels to the contralateral side, to the opposite side. The classic triad is going to be an increase in JVP, jugular venous pulsations or distension, because it's blocking off that area, pushing those vessels to the side. Systemic hypotension. If we're having an increase in pressure, we're pushing the heart and great vessels to the side. We're not going to be having as much pressure in the heart exerting on the aorta, so it's going to decrease the pressure. And pulsus paradoxus, which is similar to that, leading to that systemic hypotension. And basically how this occurs is there's some kind of trauma or some kind of event in which air can come into the lungs, but it can't go out. So it's a one-way valve from the outside going into the lungs, but when the air tries to go out, when they breathe in or out, it doesn't go out. So with every breath in, they're getting more air in because of negative pressure in the lungs, in the chest, in the thorax, but of course it can't get out. So that's tension pneumothorax. With every increase, with every breath in, they're increasing the pressure, further worsening the condition, pushing over, again, to the contralateral side, the trachea, heart, and great vessels. You need to do needle decompression emergently and a chest tube insertion. So it's a very serious condition, obviously. Next one, what heart sound accentuation will you hear in pulmonary hypertension? So what heart sound accentuation would you hear in pulmonary hypertension? So those pulmonary vessels are hypertensive. What's that going to do to the heart sounds? What is considered pulmonary hypertension in millimeters of mercury? So what is the actual measurement? How do we make the definitive diagnosis of pulmonary hypertension? And what are some of the medications that can be used to treat this condition as well? So pause there, see if you know what those are. It's going to be an accentuated S2. Accentuated S2. It's a hypertensive pulmonary vessel. So that increased pressure is pushing back. So it's going to close the pulmonary valve more strongly. It's going to push back on it more strongly. So we're going to have a louder sound. So you're going to have that accentuated S2. So the blood's going to go out of the pulmonary valve. But because the pressure is so high, it's going to snap shut quicker. And that causes a loud sound. So again, hypertension causes a strong closure of the pulmonary valve. The millimeters of mercury is over 20. So it's going to be over 20 for pulmonary hypertension. And the mean pulmonary arterial pressure is over 20 millimeters of mercury. So that's going to be what is defining pulmonary artery hypertension. We can also do calcium channel blockers, prostacyclines, PDE5s. Bosentan is one of them that we can use. And of course, oxygen, especially if associated with COPD as well. Next one, a woman on OCPs comes in with sudden onset of dyspnea, chest pain, and hemoptysis. So again, OCPs comes in with sudden onset of dyspnea, chest pain, and hemoptysis. She's also tachypnic. What are you thinking? So a bunch of classic signs here. What are you thinking is her diagnosis here? What are some of the risk factors for this condition? We already named a few, but what are some more risk factors for the supposed condition? What are rare but classic signs you might see on chest x-ray. So there's two main, I believe, classic signs on chest x-ray that we should know here for this condition. What is Virchow's triad? Important to know. And what is the most common cardiac sign, and what is the most specific? So what is the most common cardiac sign, and what is the most specific for this condition? So all these questions here are super high yield. So this is a PE, pulmonary embolism. OCPs are a risk factor. Oral contraceptives increase in estrogen. Surgery is a risk factor. Plane rides where you're not moving your legs at all, predisposed to DVT and then potentially PE. Malignancy makes you hypercoagulable. Virchow's triad is stasis, hypercoagulability, and endothelial injury. So I remember that as SHE, S-H-E, stasis, hypercoagulability, and endothelial injury, like in smoking, for instance. The two signs on chest x-ray is going to be the Western mark sign, and that's an avascular marking distal to the PE. So avascular marking distal to the PE where there's getting no ventilation and perfusion there. And also Hampton's hump. So Hampton's hump is going to be that wedge-shaped infiltrate due to the infarcted tissue there. So again, Hampton's hump and Western mark sign are those two things on chest x-ray that we might see, but they are rare. The most common cardiac sign is going to be tachycardia, of course, and the most specific, which we always want to look for, is the S1, Q3, T3 pattern. Again, S1, Q3, T3 is that important sign that we need to know on the EKG for a PE. Of course, they might also have right ventricular strain and a right bundle branch block as well. Could be possible. Okay, next one. So we're going to go through kind of the algorithm to how to handle a PE and how to work it up. So the vignettes are going to lead you in a specific direction. Try to see if you know what the next step might be. So this patient is deemed to have a Wells criteria score of 2. So what does that mean? You want to rule out PE and you think it's unlikely. What is a good test to do next? So you think the PE is unlikely. They have a Wells criteria of 2. What do you want to do? Okay, so it was right here. So D-dimer. D-dimer is what you do to rule it out. It has a high sensitivity because it detects any clots that exist in the body. So if there are any clots, then your D-dimer will probably be elevated. But it's not specific because that could just be some old clot or something. So that's not specific, but it is sensitive. You get a D-dimer, and it's positive. So next step, you do get the D-dimer. It's positive. Now what test do you want to do? So you're kind of in a pickle now. So the D-dimer is helpful if it's negative, helps rule out the PE. But if it's positive, you still have to do more digging because you can't say anything really about that if it is positive. So what do you want to get next after you got that positive D-dimer, even though you still think it's unlikely? Next would be a helical CT scan. So that's your go-to next step. It's not your gold standard, but that's your go-to next step, the helical CT scan. This happens to show an intermediate, or indeterminate rather, result. So the CT scan shows an indeterminate result. What is the absolute gold standard for PE diagnosis? So now you're starting to get concerned that they do have a PE, and you want to rule it in with the gold standard. What is that going to be? That's going to be pulmonary angiography. So again, gold standard is pulmonary angiography. Don't get that confused if they ask, what is the gold standard? That's going to be pulmonary angiography, not helical CT, but helical CT is often a good test to use. What is the treatment for stable PE and unstable PE? Also, another note on that, they might ask, what is the next best test? Helical CT is probably the next best test, but pulmonary angiography is the gold standard. So what is the treatment for a stable PE versus an unstable PE? So we have to know, are they stable or unstable? Are they hypotensive? Are they having other pathology going on? What is the treatment for these two conditions? So if they are stable, we can do anticoagulation with heparin as first line. And we need to also know that an IVC filter, if they are stable, can be used in 3 conditions. That would be if they have unsuccessful anticoagulation, it's contraindicated to anticoagulate them, or they're having right ventricular dysfunction on the echo, and that would mean the next embolus, even if it's small, could kill them. So that's dysfunction on echo of the right ventricle. Again, unsuccessful anticoagulation or contraindicated, those 3 things is when you do a IVC filter, and again, only if they're stable. But first line is definitely that anticoagulation with heparin. Then you want to bridge them to warfarin for the long term, and you need to know how long they should be kept on this. But if they are unstable, you can do thrombolysis or thrombectomy to automatically break down the clot or remove that clot. And thrombolysis comes first before thrombectomy. If they can't do thrombolysis because of a contraindication, then thrombectomy or thromboembolectomy. How long should a patient be kept on anticoagulation after this condition? And what is the PERC criteria and who can use this? So it's important to know about the PERC criteria. What is that and who can use it? And how long do they need to be kept on anticoagulation? So this is going to be 3 months. So they need to be kept on anticoagulation for 3 months. The PERC criteria, the pulmonary embolism rule-out criteria, is used in patients with a low clinical probability of a PE. If they meet all the 8 criteria, you do not have to work them up for a PE. And those criteria are, they have to meet all of these to not work them up. If they're under 50, so automatically if they're over 50, you can't use the PERC. If their heart rate's under 100, O2 sets over 95%, they're not on OCPs, they have no hemoptysis, they have no prior DVT or PE, they have no unilateral leg swelling, no surgery or trauma in the last 4 weeks as well. So if they have any of these, then you might have to continue to work them up. Next one is, what is the mechanism of action of heparin? What's the MOA of heparin? And what is the antidote for heparin? It's important to know. That's always asked. What is the antidote for heparin? Which one must we monitor the PTT in? So which type of heparin do we need to monitor the PTT? And which one is a higher risk of heparin-induced thrombocytopenia, HIT? So the mechanism is potentiates antithrombin 3. So the mechanism of heparin is potentiates antithrombin 3. And the antidote is protamine sulfate. So again, protamine sulfate is the antidote for heparin. Monitor unfractionated heparin. You need to monitor the PTT. Unfractionated heparin increases the risk of heparin-induced thrombocytopenia as well. And also for unfractionated, it has to be in a drip and IV form. That's why low molecular weight heparin is overall better, but you have to be concerned about the kidneys as well. So especially with like creatinine clearance under 30, you have to be worried about the kidneys and heparin, especially low molecular weight heparin. Next one, what measurement helps us differentiate cardiogenic pulmonary edema from acute respiratory distress syndrome? So how do we know the difference between ARDS and cardiogenic pulmonary edema? What measurement? What are the classic chest x-ray findings in ARDS? So sometimes when ARDS is the answer, they might just give you or try to describe to you the chest x-ray findings, and you have to know that that is ARDS. So what would those findings be? In addition to treating the underlying cause, what should be done? So how are we going to treat this? Oh, in treating the underlying cause, what should be done specifically? So that's going to be the pulmonary capillary wedge pressure. If it's under 18, it's ARDS. If it's over 18, then it's cardiogenic. So higher pulmonary pressure would result from poor heart function. Higher pulmonary pressure would result from poor heart function. Bilateral diffuse pulmonary infiltrates is what we're going to see. So bilateral diffuse pulmonary infiltrates, classically sparing the costophrenic angle, importantly. Why is it sparing the costophrenic angle? Because it's not in the pleura. The costophrenic angle would be like consolidations in the pleura like we saw in a pleural effusion, but it spares the costophrenic angle. It's inside the lung itself. So nothing's gathering in the pleura itself. And what should we do in addition to treating the underlying cause? We need to do PEEP ventilation, positive end expiratory pressure. That's going to be helpful in these patients. PEEP ventilation in ARDS. And again, over 18, cardiogenic. Under 18, that's going to be ARDS. Getting close to the end here, what is the biggest risk factor for sleep apnea? So what's the biggest risk factor? That's an easy one. What is the best diagnostic test for sleep apnea? And what is the mainstay of treatment for sleep apnea? So this is obesity is the biggest risk factor. Polysomnography is the test of choice. And CPAP, continuous positive airway pressure, machine that they can use at night to keep their airway open. So that's going to be the mainstay of treatment for sleep apnea. And that was actually the last one. So that concludes our pulmonary system. Thank you for watching, and we'll continue along in the next one.